Okay, thank you, Mr. Chairman, and thank you, Holger, for starting this important session, although remotely. So, just for Holger's case, we do have a risk calculator. It's called cardshock.org, or it's found in the web cardshock.org, and there you can tick all the risk variables and get the number of risk of the patient. So I think Holger uses this every day with all his patients. I hope so. So my only conflict of interest is that I'm really fan of great network, and we started our great study, Cardshock study, just because of great network. We showed our protocol 2010, and we've been working very enthusiastically. Regarding cardiogenic shock, the mortality is high, and there's a need for early risk stratification. The patient can be categorized to different risk categories. Already in 1967, Killip and Kimball did their stratification. However, it was a stratification for all AMI patients. So the class 4 was the cardiogenic shock, and the other ones were the milder cases, with class 1 being just clinically compensated patients. A very early risk stratification could aid in clinical decision making, and we really need to know when to increase the intensity of treatment. On the other hand, when are we ready to wean from the intensive therapies, and on the other hand, to avoid futility, so not to start the wrong patients these intensive therapies. The risk scores typically combine several usually independent risk markers, for example, medical history, demographics, the etiology, clinical findings, a lot of routine biochemistry, which we get from our central lab from each of our patients every time they admit, and also scientifically interesting, let's say, novel biomarkers, some of which are coming or are already in our labs, some of which are just waiting for coming clinically available. Then the response of therapy is also one component of some of the scores, which of course you can see by yourself without using any score as such. There are some validated risk scores for AMI, cardiogenic shock, Cardshock's risk score IABP2, scored by Holger Thiele and collaborators. Also their CLIP score, which I will come back to later on. And a Cardshock study included any kind of cardiogenic shock patients. So this risk score applies also to non-AMI patients, which is a difference to the others mentioned before. We already need to have specific risk scores for the contemporary patients using like VA ECMO, and these are examples of the scores dedicated for those patients, but I don't go into details in my presentation. I think this is a good, let's say, white paper of cardiogenic shock. It's a position statement of Heart Failure Association of the ESC, and you can find a lot of important information there. I took this cartoon from that, where you can see a vicious cycle and all different components of cardiogenic shock. Actually, this could be maybe like septic shock or almost any shock, showing these important things like the hypoxemia, acidosis, liver injury, bowel permeability, acute kidney injury, and also thrombotic complications. And in cardiogenic shock, the origin is, of course, cardiac. This is a busy picture. I'm not quite sure if Holger showed this, and I'm not going to go into details. Many of the green or red boxes are from Holger's ingenious work, where he has done lots of randomized trials in showing us what to avoid and what to do. And you have a lot of these, let's say, these orange or yellow boxes, which we are not very certain. Should we use, they kind of should be considered or may be considered. And I think a risk score helps us in those decision-making processes. Also, one important point is there is the palliative care. Some patients, just to avoid futility, will end up to palliative care. The Society of Cardiovascular Angiography and Intervention classification was mentioned in the previous talk, and I won't go into much details. Actually, it shows a continuum of patients, not exactly yet in the cardiogenic shock, but already, but also at risk, or in those who are beginning, maybe beginning to have shock, because the hypoperfusion is the most important thing in defining cardiogenic or in defining any kind of shock. So here we can see the observed mortality, the intensive care mortality, hospital mortality, and they are very different in these patients, of course. And the extremis patient who has hypoperfusion with deterioration and refractory shock has mortality in hospital mortality of almost 2/3. Here you can see also the let's say the distribution of the patients. If you take off my picture for a second, so we can see also the stage E, or we might see stage E, which is just like 1% of all the patients included in this registry. So the most severe cases, happily, are the most rare. This is just to show the variables included in different scores. So we included here in this analysis the sleeper score, which is from the Judith Hoffman's shock trial in the 1990s, the card shock risk score, Holger Thiele's IABP shock 2 score, and their CLIP score, which is most recently published. And you can see that in the left side panel we have, let's say, clinical history or clinical findings, ejection fractions, and so on. And on the right-hand side, you already have biomarkers, quite different biomarkers, and also then findings either in the, I think those days, much by ECG, maybe somewhat also with echoes, and then the TIMI flow, so which is the treatment response. Lactate is the biomarker of hypoperfusion, the most important one. And in cardiogenic shock, in our study with 217 patients having the lactates, the median level was 2.8. And in the quartiles, in the highest quartile, the median was already 8.3, which you saw actually in the SCAI definition that over 8 is typical in the extremis population. You already can see that lactate on baseline is all the time more important prognostic factor than lactate at a certain single time point, even though these lactates also are predictive. But the baseline value is very important and maybe good enough. But then if you think about the relative change, so the relative change, of course, is also a good prognostic factor, so more than 50% decrease. In this figure, you can see the Kaplan-Meier curves regarding those quartiles, and in the best population with actually only mildly elevated lactate. The mortality is just like less than 10%, and in those with around 8, you have like 70% mortality. On the other hand, on the right-hand side, you can see that in those patients who survived 30 days, the lactate goes down quite quickly. There's a huge drop, and these are hours from the start of the study, and in those who died, there is much less decrease. These are the components of IABP shock 2 risk scores, and without going to all these details, I just want to highlight that it's very valuable that you classify the patients already by these numbers to low, intermediate, and high-risk patients, and you can then decide how to use them in clinical practice. Also, you could use them in planning randomized controlled trials, because if you randomize these patients to, for example, ECMO study, you are waiting for much less benefit than maybe in this population in the middle. Are these patients lost anywhere, anyhow? That is also a very good question, which I cannot answer. I will now go to CLIP score and just show that also in Holger Thiele's culprit shock study, they analyzed quite a few biomarkers. They had 458 patients, and they analyzed 28 different biomarkers, and out of that regression study, they found these 4 markers clinically significant, or the most significant, made a score out of cystatin C, a kidney marker, lactate, interleukin-6, which we heard already in the first session, and NT-proBNP. And here you can also see that you can classify these patients very well. They say that this is a fast and objective biomarker, so you don't need to see the patient at all. You need to just look at the computer, so you can decide which combination you use in your real-life practice. But their message was that biomarkers are very important, and here you can even see that the CLIP score performed almost like better than CLIP score on top of IABP shock score. Antonio Baez Genis did an excellent analysis by making a panel of proteins. They made a mass spectrometry and characterized 2,654 proteins, and out of them, from our CardShock cohort, they found like 50. They looked at 51 protein candidates, and out of them they found 4. And without going to the detail, I think this also shows that sometimes we get results which are not clearly applicable in our everyday practice. So fructose biphosphate aldolase or serbin G1 are not ready in our everyday practice yet. And this is to show that the causes of cardiogenic shock are diverse, so almost or even 40% of the patients can be non-ACS population. So it's important to have a score which includes not only ACS patients but also those without ACS etiologies. We see from CardShock's risk score that you get 1 point out of the 9 from ACS etiology, but we have a lot important variables. Out of it, we can then categorize our patients. Some colleagues are then less enthusiastic maybe and say that whether we are having too many scores but too little information. Of course, like I already before said, we need to do some kind of randomized trials by using the data from these. And sometimes the data from scores is just as good as the clinical gestalt, so your feeling as a clinician. So medicine is not mathematics, but let's see who scores the most on Saturday. Thank you.
Okay, we have time for one question, so make it count.
Yes, Holger's patient got 2 points from cardiac risk score.
Thank you. Short question. Lactate is venous, arterial, or is the same? Venous or arterial?
Yes, in most patients it was arterial blood. Actually, I'm not fully aware whether any of the patient had venous blood. So in these intensive care patients, it was drawn from the arterial line.
Okay, thank you.